Get started here. Good morning, everyone, and welcome back to Security Health Plan Academy. This month's webinar topic focuses on the importance of preventive care. Our presenter for today is Dr. Karen Shulman. Dr. Shulman is a family physician with Marshfield Clinic Health System, and she's also the Director of Adult Primary Care. Dr. Shulman has been practicing medicine for 27 years and is here today to speak about current recommendations for preventive testing and how those do change over time. So Dr. Shulman, go ahead. It's on you.
Thank you for that great introduction. Yeah, I've been with the Marshfield Clinic for 24 years as well, almost entirely in practicing in primary care.
Oops. So I think we gave you an extra 3 years.
No, I've been practicing medicine for 27.
Oh, okay.
I've just only been here for 24.
Perfect.
Thanks for having me. I'm pretty passionate about this topic and I tend to talk a lot. So I'm going to try to get through this as quickly as I can. So there's plenty of time for questions at the end. Why are you not forwarding? Go. I'm sorry, my computer's being very sluggish. There we go. So recommendations for preventive health care generally come from the guidance of the U.S. Preventive Services Task Force. The mission of the task force is to improve the health of people nationwide by making evidence-based recommendations on effective ways to prevent disease, promote health, and prolong life. It's a multifaceted group of people. They do change out every few years. Researchers, physicians, statisticians, scientists, everybody gets together and does a deep dive into all the pertinent information that's available related to health maintenance, preventive health screening, testing, cancer screening, everything you can think of. And based on the quality of the data and the amount of the data, they make recommendations on a periodic basis and update them as necessary as new information is available. So why do we recommend preventive services? Keeping up with your periodic health screening tests can really have a significant impact on the quality and the quantity of your life. So recommendations are based on current research and they have to prove to be not only beneficial, but they also have to be free of any harm by making the recommendation. They do change from time to time based on newer or emerging data as additional studies are done. So the USPSTF sends out recommendations of various grades. So grade A, there's high certainty that there's a good benefit for doing that test or making that recommendation. Grade B means there's high certainty that the benefit is at least moderate, or at least moderate certainty that the net benefit is moderate to substantial. So A's and B's across the board are pretty much recommended that we offer this service. Grade C recommendations are a little tricky. Generally, they are recommended, but only in select populations or after specific discussion has been had with the patient. More on that later. So grade C recommendations are things like PSA testing. Grade D recommendation is that they actively recommend against doing this service. So there's moderate or high certainty that there is no net benefit or that the harm of the test may outweigh the benefits. So those services are discouraged. A lot of things fall under the I, which is inconclusive, and they usually put out a statement about anything that falls into this category. Inconclusive, insufficient, basically there's just not enough evidence to balance the benefits and the harms, and so, or the quality of the evidence is lacking, they don't have enough of it, the studies are not good, or they conflict. So they can't make a reasonable recommendation for or against. So these are some of the common A and B ratings. Well, it's all the A and B rated recommendations. Things you're very familiar with: cervical cancer screening like pap smears, colon cancer screening like colonoscopies and Cologuard, getting your blood pressure checked every year, screening for cholesterol disorders, tobacco screening, alcohol screening, depression screening, osteoporosis with bone density tests, mammograms for breast cancer, and general health counseling all fall into these categories. So I broke up the recommendations into chunks that you might experience when you go to the doctor. When you first get there, you're often faced with a bunch of questions because it may be the MA or the nurse who's rooming you will want to complete some questionnaires. Alcohol use, depression. If you're being screened for depression, you've never had it before, they'll do a quick two question questionnaire. And if you answer and the score is a little too high, they will then carry on and do a full 9 question screening test and then share that with your provider for further discussion. Tobacco use, similar with alcohol use, it's usually, do you smoke or use alcohol? If so, how often, how much, and how long have you done it? Because these answers play into making recommendations for preventive testing down the road, as well as counseling around your health. Intimate partner violence, women will often be asked if they feel safe at home and offered support if they screen positive. And if you fall into a high risk category for family-related breast cancer due to BRCA gene, you can also get that testing offered. So then the screening lab work. This is a topic of hot discussion in a lot of for insurance companies these days, because not everybody needs all kinds of blood work every year. It's not cost effective, it's not helpful, and it can be complicating if you're otherwise healthy. If we find an unanticipated problem, that's not really a problem, it's just abnormal. So if you're overweight or obese, age 40 to 70, you should be getting your blood sugar screened every year. Lipid screening is actually only every 5 years. There's no evidence that treating with statin therapy until the age of 40 makes a difference. So screening between 40 and 75 every 5 years is the CDC recommendation for cholesterol screening. Everybody should be checked for hepatitis C once, particularly if you're born between 1945 and 65, or you're at high risk due to lifestyle. HIV screening yearly up to 65 is recommended. So are some of the other tests, hepatitis B, syphilis, chlamydia, gonorrhea, mostly geared toward high-risk people. PSA, we have a lot more to talk about that, so we'll get there. Then the cancer screening, cervical cancer screening, Pap tests every 3 years from 21 to 30, 30 to 65, you can continue every 3 years or get a Pap plus an HPV test every 5 years. If you've had good screening up to the age of 65, you no longer need Pap smears after that age. Routine pelvic exams are also not recommended anymore. If you truly don't have any symptoms, just checking with, what we call the bimanual exam is not super helpful. And sometimes it deters people from coming to the doctor or following up for their routine exams. Colorectal cancer screening is approved from 45 up to 74. You can do yearly screening, looking for occult blood or with a FIT test, which is just a stool sample smeared on the card that some people may be familiar with, and you mail it in. Cologuard is a kit that's mailed to your home. It's another stool sample, and then you mail it back to be tested. And then colonoscopy is really the gold standard. If you're low risk, every 10-year colonoscopy is recommended. If the Cologuard or the FIT tests come back positive, then the next step is colonoscopy. My recommendation generally is to consider getting the last test first and just go with colonoscopy. It really gets a good look at everything. If there are any polyps, they can be removed before they have a chance to turn into something worse. Other screens are available, such as sigmoidoscopy that checks about the first third of your colon, doesn't go all the way around, and CT colonography. You still have to do the full prep for CT colonography. It's just not a colonoscope that goes into you. They just have you, it's a dye study. And then you have the CT test, which has radiation included. We don't do a lot of either sigmoidoscopies or CT colonography. Colonoscopy is really the superior test. Breast cancer screening with mammography. The USPSTF recommends every other year between 50 and 74. And from the ages of 40 to 49, there are lots of other factors in play that it can be considered. It's not discouraged, but it's not strongly encouraged due to the high risk of false positive findings on mammography in premenopausal women. Lung cancer screening, with a low dose CT scan is how we do lung cancer screening. Chest x-rays are pretty poor at picking up early evidence of lung cancer. People who have smoked a pack a day for a year, that's 1 pack year. If you have a 30 pack year history of smoking and you are either still smoking or quit less than 15 years ago, you would qualify for yearly low dose CT scanning of the lungs for lung cancer screening. It's indicated between the ages of 50 and 80. Currently, Medicare is covering it up to about 77. Things do change as far as coverage as the USPSTF makes changes to their recommendations. It often lags by a couple of years. Hypertension screening, you're going to get your blood pressure checked every time you go into the doctor's office, or I hope you do. If your blood pressure is elevated in the office, they recommend that we get a couple of blood pressure tests at home. Some people have what we call white coat hypertension. You have high blood pressure at the doctor due to anxiety. So getting a couple of readings at home can help guide whether you truly do or do not need medication for hypertension. Screening for osteoporosis with bone density tests. Women 65 or older are all encouraged to get osteoporosis screening. It's covered every other year. If your results are normal, you probably don't need it every other year. Bones don't change that rapidly unless you're at high risk. If you're postmenopausal and you have other risk factors, you may be tested sooner than 65. And similarly, if men are at high risk, we will recommend bone density screening for them. Risk factors would include things like being very thin, smoking, chronic steroid use, and some medications. Men between the ages of 65 and 75 who have ever smoked, and I think the guidance is if you've smoked 100 cigarettes at any time over your lifetime, you would qualify for a one-time screen with an ultrasound of your abdomen to check for aneurysms in the aorta, the main artery that brings blood from your heart down to the rest of your body. We may consider screening men who don't smoke if they have other high vascular risks, or women who smoke if they also are high risk. The grade C recommendations, here's a prostate cancer screening. PSA screening's been sort of around the block in the last few years. We went from doing it every year on every man to not doing it at all. It was actually, I think, a grade D recommendation for a short period of time. But as more evidence has come through, the recommendation now is that we may consider doing PSA testing in men between the ages of 55 and 69 after shared decision making has been undertaken. So the discussion that needs to happen, and what I want everybody to understand, is that it's not just a blood test. This blood test can be false positive. It can be elevated if you have a viral infection, if you've had recent sexual activity, if you've had a recent infection in the prostate. So elevated PSAs may then lead to further treatments or further diagnosis, including things like biopsies that come with some discomfort, risk of bleeding. Overdiagnosis, something looks like it might be cancer and is called cancer, but really isn't cancer, which could then lead to overtreatment. There are lots of different treatment courses that men can choose. Everything from watchful waiting to radiation to full prostatectomy, which has some significant side effects and chronic changes a lot of the time associated with it. So there's a lot to consider when you're thinking about having a PSA screening. The older men get, it's very likely that prostate cancer starts to develop in the prostate. The majority of 90-year-old men probably are walking around with prostate cancer. By and large, as you age, it's a disease that you would die with rather than die of. In the younger populations, it can be more aggressive, and hence the age range is about 55 to 70. Some men choose not to be screened. which is also appropriate if you're, depending on what your risk benefit makeup is. Some people want to know everything, even if it leads to additional treatment. Some people don't want to know anything until they're symptomatic. Checking PSA for symptoms, I just want to be clear, is no longer in the screening realm. If you're having urinary symptoms, the doctor may want to do a digital rectal exam and get a PSA. That's not screening anymore. Screening is specifically for people who do not have any symptoms at all. It's in order to catch problems at a stage early enough where if we intervene, it can make a difference to the outcome. That I should have said that up front. That is the basis of the screening test and what is kept firmly in mind as we make these recommendations. That it's one thing to find a disease early, but if there's no point in finding it early because you can't intervene anyway, we tend not to think screening is a good idea. So we recommend against a bunch of things because they could cause harm or they're of very little benefit. As it turns out, pelvic exams, self-breast exams, even clinical breast exams by your provider don't really add a lot to cervical cancer screening and mammograms. So if you notice you don't get undressed at your physical anymore, that's why. We're trying to keep things comfortable. We're trying to keep them efficient. If somebody wanted to have their breast examined, I'm sure providers would be happy to oblige. But if they're not offering it, it's because they're really not strongly recommended as screening. The rest of this list, you can see, I'm not going to go through them individually, but generally on balance, it either does not make enough of a difference to the outcome of the disease by finding it early, or it's cost prohibitive to find it early enough. The prostate screening with PSA in men 70 and older, we touched on as well. This is the list of things that it's really up to us. There's not enough evidence to recommend for or against. So digital rectal exams are generally not recommended in combination or alone. They're not a problem per se, but many men find them uncomfortable, embarrassing, and it can deter from people wanting to go to the doctor. Similarly with the pelvic exam, clinical breast exams, and doing things like checking your thyroid, TSH, vitamin D in a healthy person who's living in the community. Sometimes we do it in nursing home patients, but that's for other issues. And all the other screening tests listed here, not really sure whether I would do them if there were risks involved and if the risk benefit ratio I thought was appropriate to go ahead with testing. So when you're going in for your appointment, you want to be able to know what your insurance does or doesn't cover. This tends to change on a yearly basis in some cases, so make sure you know what preventive screening you are covered for. Medicare, by and large, does not cover preventive screening per se. There are, preventive lab work is very difficult to get covered. The annual wellness visit is covered as a way to review your medical conditions, what your risks are, what preventive screening you may be due for. That Medicare does cover and recommend. Things like your mammograms, your colonoscopies. Make sure you ask your provider about anything that you don't understand. If something's being recommended to you or not being recommended to you that you think should be, they should be able to clarify any of the concerns you'd have. So come prepared to ask questions. Educate yourself about what you think you might be due for. Sometimes it's a good reminder because we can get focused on all the medical issues. But if you really want to get your preventive screening done, make sure once a year, that's going to be your priority to get covered. We try to make it a priority for ourselves once a year. Sometimes it's, we get sidetracked on other issues. So you're also allowed to decline anything we recommend. It's all in the discussion, right? Some people are not comfortable going ahead and they're comfortable taking the risk, and that's okay. Our job is to counsel you as to why some tests are suggested, some may not be in your best interest, and help you make the decision. And the final note that I like to spread the word, you may not always be in need of a yearly checkup. Generally, as we get older, things crop up that you need to be seen at least yearly, if not every 2 to 3 months. But younger folks sometimes don't need to come in every year for the yearly physical. No medications, there's not a lot of screening to be done on a yearly basis, at least until you become 40 or 50. So again, when we're not having people in routinely, that might be the reason. All right, well, I think I covered that quickly enough. Do we have time for questions?
Yes, we're great on time. Thank you so much. I do have a question for you. The question is, can you hear me okay?
Yeah, it was just going in and out a little bit.
Oh, sure. Okay. Hopefully this is better. Will my provider let me know when I am due for screenings, or should I keep track of a schedule as well?
That's a great question. It doesn't hurt to keep track of your own schedule. However, by and large, the vast majority of providers now have electronic health records that we work from, and they all come with a standard tool that helps us keep track of the health maintenance screening, when things are due and when they were last due. If I'm just going to put this out there also as a heads up for anybody who goes to the Marshfield Clinic, as you may have heard, we're transitioning between two different electronic health records, and the homegrown cattails hasn't. Sometimes all the data hasn't migrated perfectly into Cerner. We do have access to cattails, and we can go back and see what was done. But the more you may have knowledge of what, when your last mammogram, your last colonoscopy, just in case, that's a good thing to know. But by and large, all the EMRs are going to help us keep track of what you're due for and when.
Okay. Another question I have from the audience. I am nervous to get bad news from these screenings. Information, of course, it's good to have, but what if I have concerns?
That is an excellent question. That's exactly why a lot of people decline getting screening, and that's why I would also recommend you talk to your provider about that. It is tough to hear bad news. And this is, so back to my statement about why we do screening testing in the first place. Preventive screening is geared primarily to finding problems before they become a big issue. Everything that is recommended to be screened for, we either have treatment for or mitigating recommendations that can make it, whatever the problem is, can make it go more slowly, that we can intervene and take care of it early. So preventive screening is always going to act in your best interest if we find something. It means we have a better than average chance of making a difference in how sick you might get, or what your lifespan might be. So having said that, it's still better for a provider to understand why somebody may be reluctant to undergo the screenings if you have a fear of something being wrong. And that's understandable. It goes back also to, you are in charge of your healthcare. If after hearing all the information and on balance, you decide that the right thing for you is to decline testing, and I do have my share of patients who follow this rule too, it would be okay. Well, all we ask is that, you come back, you continue the conversation, you let us continue to take care of you, do what we can while we're in the office, and just make sure that you find somebody you trust enough to come if you do develop problems and you're not, and you want to work on things together.
Perfect. One other question that we had submitted, I think this was pretty extensively covered, but I'm just going to, maybe as a closing question, can you reiterate why PSA testing is no longer covered as preventive care? This has to do with the prostate cancer.
Absolutely. And yeah, since I was a little nervous about going too long, so I can spend a little more time on the PSA. So the problems with the PSA, as we talked about before, are myriad. Everything from false positives leading to testing that may not have been necessary, like biopsies. Biopsies can have complications that then lead to bigger operations. You know, it can be a whole downward spiral of harm that we could inflict on people without really having to. Prostate cancer itself, I liken it to breast cancer in women. It's not just, you know, one single discrete disease. It behaves differently in each person. You know, we all have patients who were diagnosed with prostate cancer at 70 and are doing fine at 92, never having had treatment. We also know people who have had prostate cancer and it was very aggressive and really got out of the barn and wreaked havoc pretty quickly, despite the best treatments. So it's unclear a lot of the time how best to approach prostate cancer diagnosis. Oncology and urology have really come a long way in helping risk stratify the type of cancer, the stage of the cancer, and making the best recommendations for treatment. So I think that's why we're back to covering PSA testing or recommending PSA testing for that discrete age range from 55 to 69. Earlier than that, on balance, it's not cost effective to screen younger men because their false positive rates tend to be higher due to the other issues I mentioned before, you know, whether it's infection, sexual activity, etc. And the older gentlemen are very likely to develop prostate cancer, but is very unlikely to require much interventional treatment. And in fact, in many cases, probably most cases, as the evidence had borne out, if you go ahead and treat at an older age for a diagnosis of prostate cancer, there may be unanticipated problems with, you know, bowel or bladder function, operative complications. And sometimes it's best just left to watchful waiting in the older age group. So if they become symptomatic, we happen to find prostate cancer, it's treated differently than if you're 55 years old and you have a more aggressive form of the cancer. So as far as your insurance not covering it, I think it may just be because you don't fall into the age range, or some insurances make their decisions outside of USPSTF recommendations. By and large, Medicare, CMS, Centers for Medicare and Medicaid Services, tend to follow the USPSTF recommendations pretty closely, at least within a couple of years of any changes as well.
Okay. Well, thank you so much, Dr. Shulman, for joining us today. A very informative presentation. And I think our guests would agree it was great. With that, I think we can go ahead and close. I think a few minutes, well, 2 minutes early, so not a whole bunch, but
everybody can get 2 minutes back in their day.
Yes, yes. Thank you so much for joining us today.
Thank you for having me. I hope it helped.
Yes. Be well, everyone.